And can I just first of all welcome everyone up to Parliament buildings. You wouldn't know it by looking outside now, but the snow is pretty bad right across the province at the moment, and I know that some people have had difficulties in getting here, and indeed some of the members have had difficulties getting to committees during the course of the day as well. But I'm delighted to join you today. I'm the chair of the Justice Committee, took over from Paul Given just before Christmas, so I'm very much finding my feet in that role. This seminar today is going to focus on population mental health and links to bereavement and suicide. Here in Northern Ireland, around 300 people a year are dying because of suicide, with some families losing more than one close relation. Mental ill health is, of course, a broad concept ranging from worries experienced as part of everyday life to more serious conditions such as depression, addiction, bipolar disorder, schizophrenia, and eating disorders. These conditions may be long-term and need to be managed, for example, through medication. Mental ill health is a major contributor to the burden of disease in society and knows no boundaries. However, certain mental health problems are more prevalent in certain groups. For example, women are more likely to experience anxiety disorders and depression, and men are more likely to experience addiction, personality disorders, and suicide. There are a wide range of known factors that increase the risk of developing a mental health problem, such as traumatic life events, deprivation, unemployment, bereavement, and physical illnesses. The Health Survey Northern Ireland 2013-14 published its first results in November 2014, which, amongst other things, revealed 1/5 of respondents showed signs of possible mental health problems. This was particularly true for females rather than males, and young females were especially more likely than young males. Further results showed that twice as many respondents in the most deprived areas showed signs of possible mental health problems, much greater than those in the least deprived areas. Moreover, the suicide rate is twice as high in deprived areas, and males are 3 times more likely as females to die because of suicide. Young males in deprived areas are particularly vulnerable. The picture I've highlighted of mental health amongst the general public in Northern Ireland is similarly reflected in the criminal justice system. In a 2014 report by the Criminal Justice Inspection Northern Ireland and RQIA, statistical findings evidenced the prevalence of mental ill health in prisons. According to the report's figures, a total of 25% of women and 15% of men in prison reported symptoms indicative of psychosis. 46% of women prisoners surveyed reported attempted suicide at some point in their lives, and 49% of women in prison suffer from anxiety and depression. The figures for young offenders are also worrying, as statistics indicate that around 1/3 of young offenders had undergone some form of mental health intervention. The Assembly takes a consistently active approach to tackling issues around mental health and addressing the issue of suicide. In 2008, the Committee for Health undertook an inquiry into the prevention of suicide and self-harm. Its report recommendations informed the implementation of the Department of Health Suicide Strategy Protect Life and the subsequent refreshed strategy that came after that. The Committee for Justice has also taken an active interest in the issue of mental health in the criminal justice system. The Committee commissioned research from the Assembly's Research Information Service on mental health in prisons, which is available on the Assembly's website. The Justice Committee also heard evidence from the Prison Review Oversight Group on its second annual report in June of last year about the cost incurred by the prison service when addressing mental health issues and the need for significant investment to support both the health service and the prison service to deliver mental health services and social care. This year we'll see the introduction of the groundbreaking Mental Capacity Northern Ireland Bill. The bill will bring together mental capacity law, which will support people who are unable to make specific decisions about their health, welfare or finances, and mental health law, which concerns the detention and treatment of people with a mental health disorder, bring them together into a single framework. This approach is a novel approach, and unlike the rest of the United Kingdom, where mental health law and mental capacity law are governed by 2 separate pieces of legislation. Both the Committee for Health and the Justice Committee here at Stormont have taken an interest in the development of this very important piece of legislation and have been briefed by officials from both departments and by stakeholders during the various stages of policy development. A joint committee will be established in due course, bringing together members from both committees, which will scrutinise and assist the passage of this bill. If we can turn just to the seminar that you're all here for today, the presentations that you're here and the research findings on 3 themes which are to be highlighted and help to inform the Assembly work in the area of mental health. First, Dr. Aideen Maguire, Dr. Mark McCann, Dr. John Moriarty and Dr. Dermot O'Reilly, all from Queen's University, will present an innovative method using administrative data for the purposes of gaining an accurate picture of population mental health, determining associations and calculating risk. Second, Dr. Sharon Mallon from the Open University and Dr. Karen Galway from Queen's University will provide a dual-focused presentation that provides an examination of a 2-year cohort of suicides and explores how bereavement issues affected those who died, as well as looking at the impact of how those deaths impacted those who were left behind. I'd like to have a particularly warm welcome to all of our speakers here today. I'm sure everyone's looking forward to their presentations and the discussion that will come about after that. Unfortunately, I'll have to leave because the Justice Committee is meeting very shortly and I have to chair that meeting, but I'm quite sure that everybody will find this afternoon a fruitful endeavour, and thank you very much for listening to me. Thank you.
Thanks very much, folks, and thanks, Alistair, for that introduction. I'll just double check that this is working okay. Great. Like Alistair said, my name's Aideen Maguire. I'm a research fellow at Queen's University in Belfast. I'm going to talk to you today a little bit about this idea of utilising administrative data to measure population mental health, and present very briefly some research findings from 2 exemplar projects which have utilised this method. Just to set a little bit of context then for you, and I know Alistair already has highlighted the magnitude of the mental health problem in Northern Ireland, but just so you know, Northern Ireland consistently has worse mental health than the rest of the UK, and mental health issues such as depression and anxiety are placing a growing burden of disease in society. They affect not only the individual but the household and society as a whole. An individual coping with depression, individuals within a household living with someone with depression, it affects society in terms of worklessness, joblessness, sick pay, sick leave, and therefore also affects government budgets. So there's a need to understand what causes poor mental health, what are the risk factors, who are those most affected, and as importantly, who is resistant, who are the individuals who do not suffer from poor mental health and what sets them apart from those that do. This is a high priority not only in Northern Ireland but in the rest of the UK, and Deputy Prime Minister Nick Clegg before Christmas was actually quoted as saying that in his next party manifesto he aims to increase the research budget for mental health research by 50 million by 2020, I think. But he's quoted as saying that we should understand poor mental health or mental ill health as well as we understand physical ill health, and it's a standpoint that I actually strongly agree with. Currently, mental health in Northern Ireland is measured predominantly by surveys, and Alistair actually quoted some of the surveys earlier today, but there are huge disparities in the population estimates of poor mental health based on these surveys, from 1 in 5 in the health survey for Northern Ireland to 1 in 20 in the Census and the Survey of Activity and Living Disability. So depending on which survey you look at, you will have estimates that 1 in 5 of us suffer from poor mental health or 1 in 20 of us suffer from poor mental health. There's a need for a more accurate measure, for something different. And surveys themselves have their own problems. They are expensive to start with, and in an area where only 4% of the research budget is spent on mental health research, we need to find something that's a little bit more cost efficient. They are time consuming and labour intensive. They're subject to a variety of biases, and mental health still has a huge stigma attached to it. So individuals may be unwilling to identify themselves as suffering from a psychological disorder if they believe that that's not socially acceptable. And surveys, whilst they try to be representative and try to gain a representative sample of the whole entire population, they tend not to be. A lot of research has shown that individuals who are married, females, those with the higher socioeconomic status, and older people are those that are more likely to respond to surveys. They're the ones that when an envelope comes through the door, they'll fill it in and send it back. And these factors are also associated with mental health. Surveys often don't gain information on young men or individuals living at institutions or those that are hospitalised, those that are most vulnerable to mental health problems. In terms of longitudinal studies also, surveys have very high attrition rates, and there are very few longitudinal studies which follow individuals over time to gain information on mental health trajectories. So there's a need for a better measure, and whatever measure we have is not going to be perfect. So it's not about finding the perfect measure, it's about finding the best possible measure to measure population mental health. And I believe that we already have that in Northern Ireland. It's something that already exists that we're just not utilising, in the form of administrative data. Using prescribing data to identify population mental health looking directly at poor mental health by accessing information on psychotropic medication that is dispensed to individuals living in Northern Ireland. And by psychotropic medication, I mean antidepressants, anti-anxiety medication, hypnotics, antipsychotics. And this information is gleaned from the Enhanced Prescribing Database. The Enhanced Prescribing Database was established in Northern Ireland in 2008 and contains information on all medications dispensed in community pharmacies in Northern Ireland. It was initiated as a pharmacy reimbursement tool, and that's mainly what it's used for. But within the Enhanced Prescribing Database is a wealth of information on the population health of Northern Ireland. At a glance, you can look at the prescribing database to see what the entire nation is being prescribed to get an insight into their health. Not only that, not only the health indicator in terms of prescribing data, the Enhanced Prescribing Database also contains information on the individual, their GP practice, and importantly, an individual's health and care number. This is unique to every individual, is assigned to you as soon as you register with the GP at birth, and means that this information on prescribing can be linked to other data sets which already exist. Other data sets which are collected for administrative purposes, which may give more information about the individual receiving these medications. The premise being then, for this measure, that we're looking at prescription medication as an indicator of poor mental health. For sensitivity analysis, we rule out the one-off prescriptions for diazepam. If you're a poor flyer, and you get a one-off prescription, that's fine. We won't look at you. But we assume that if you have, a 12-month prescription repeatedly for Prozac, that you suffer from some form of mental disorder. We can link this to census data. So we can look at an individual and say, this individual has potentially poor mental health. We link it to census data to gain information about their demographics. Where do they live? Who do they live with? What's their education, socioeconomic status? We can also link it to death data from the General Registrar's Office. So we can gain information on poor mental health and risk of death by a range of factors, risk of death by cancer, risk of death by suicide, etc. Now, this linkage has already been carried out. We'll talk about this later in the presentation. But there are a range of other administrative data sets which exist in Northern Ireland that aren't being used effectively that we could potentially link to the prescribing data to gain a more accurate picture of who in Northern Ireland suffers from poor mental health. Because of the health and care number, we can very easily link it to other healthcare records. We can link it to hospital admissions to look at poor mental health related to admissions for self-harm. We can link it to GP data to look at comorbidities and diagnosis information. We can link it to availability of alternative services, and this is something that hopefully will be available in the future. But we can also excitingly link it to other sources of administrative data, such as education data and benefits data. So we can look at the school censuses over the years and look at educational trajectories and risk of poor mental health. We can look at poor mental health and likelihood to be claiming benefits. So the three highlighted circles here are data sets which have already been linked. And this seems quite simple, but was a long, arduous process over about 2 or 3 years of gaining data access, ethics approval, and assuring that the data would be fully anonymised. And from this linked data set, myself and John are going to present to you a range of research questions that we were able to answer from this. But I want you just to bear in mind when you're looking at the findings that we're presenting, the possibilities that are available by linking all of these other administrative data sets which exist, which are not yet linked. Just very briefly, I'm going to talk about a piece of work that I carried out looking at psychotropic prescribing from the Enhanced Prescribing Database, linked to 2001 census data from the Northern Ireland Longitudinal Study. And the Northern Ireland Longitudinal Study is a representative sample of the Northern Ireland population, about 500,000 people, and we linked the prescribing data to this to gain demographic information on who is being prescribed antidepressant and anxiety medication, etc. And basically I wanted to ask the question, who suffers from poor mental health in Northern Ireland? Is it related to where they live or other area factors? And how does poor mental health vary in terms of gender, age, marital status, education, socioeconomic status, GP practice, etc.? So this slide very briefly shows a graph looking at the percentage of individuals receiving medication over the study period, stratified by gender, looking at antidepressant medication, anxiolytic medication, and either drug. Pink bars represent men or women, obviously. The blue bars represent men. And along the y-axis is the percentage of the population. And instantly when you look at that graph, you can see that women consistently have twice the proportionate uptake of medication as men. And this corresponds with other research which has shown that women consistently have twice the proportionate worse mental health than men. What's interesting though is if you look at the far right column, which is either drug, either medication, over the study period, 15% of Northern Irish men received this medication and over 25% of Northern Irish women. There's a staggering amount of individuals receiving this medication. In terms of demographic factors, then we break it down and try to look at more details. Medication uptake increased with age up until a peak age of about 55 years and then began to fall off again. And this was true for antidepressants, antipsychotics, etc. But for anxiolytics, it actually increased into older age. And I've done a separate piece of work looking at diazepam prescribing in older age. You can talk to me after if you want to about that. In terms of marital status then, married individuals were actually 16% more likely to suffer poor mental health than single individuals. May not be a surprise to some of you in the audience, but it's probably more to do with help-seeking behaviour. Individuals who were remarried or separated and divorced also had worse mental health. Individuals with no qualifications, those who had never worked or were long-term unemployed, and those living in rented accommodation were also at increased risk of poor mental health. This is highlighting the fact that we know that poor mental health is related to socioeconomic status. When we looked at variation by GP practice, we were able to see that we looked at each of the medications, but I'm just going to present here on antidepressant medication just for an example because the trends were the same for every medication. We saw that the lowest prescribing practice, only 3.5% of individuals in that practice receive antidepressants, whereas in the highest prescribing practice, over 20% received antidepressants. That's about a 7-fold increase. Now, it seems a little bit shocking, but whenever you look at this in detail, actually individuals who were in the highest prescribing practice, they themselves were more likely to live in rented accommodation, never have worked, be divorced or separated. So it's more to do with the population that a GP practice is serving than the practice itself. Uptake of medication was also mapped by geographical region. And again, the trends were the same for anxiolytics and antipsychotics, so I'm just presenting here on antidepressants so you can see what the uptake of this medication was like throughout the province. Darker areas show higher uptake of medication, lighter areas less uptake of medication, and you can see the higher uptake is clustered around urban areas, around Derry, Belfast, and what seems to be Craigavon or Armagh. What's interesting is that this map correlates with the map for deprivation. That higher uptake of antidepressants is associated with deprivation as well. That individuals living in deprived areas are much more likely to receive medication than those living in more affluent areas. Individuals living in rural areas were less likely to have poor mental health than those in urban areas. And interestingly, individuals living at peace lines were at an increased risk of poor mental health compared to similar populations who didn't live at interface areas. So that was a whistle-stop tour of my research, just to give you a little bit of an introduction to what kind of questions we can answer from these linked administrative data sources. Currently, I'm working on a number of other projects. There's a list of them here. The first looking at early life exposures and likelihood of poor mental health. So early life exposures such as low birth weight, gestational age, mother and father's income, etc., linked to mental health, again as measured by psychological or psychotropic drug uptake, and also by linking it to death data, looking at deaths by suicide. Second project is looking at address changes in early childhood, so looking at migration within the country and mental health in young people. And the third project looking at familial influence on suicide. So this is just from the 3 linked databases that we have initially been working on over the last few years. There's huge potential to gain an awful lot more information about population mental health by linking to these other existing administrative data sources to answer a whole range of research questions. I'm going to hand over to John now, who's going to speak in a little bit more detail about a project that we carried out last year, again highlighting the range of questions that can be answered by linking administrative data.
Thank you. As Aideen said, my name's John Moriarty, and Aideen and I were fortunate enough as young postdocs to be recruited to carry out this research by Dr. Mark McCann and Dr. Dermot O'Reilly, who are both serial users, massive enthusiasts, and really pioneers of this kind of data research and the use of these approaches and resources to detecting mental ill health in the population, and indeed population health at large, and who will be here again in 2 weeks' time presenting their research on admission to care homes and what linked administrative data can tell us about that. In terms of the actual project that we undertook, the grief study aimed firstly to look at whether bereavement led to increased risk of poor mental health as measured by the use of the use of the type of mental health related prescription substances which Aideen has been speaking about, and to try and identify the groups which suffer most commonly from mental ill health following bereavement. And in essence, it sounds like quite an obvious question, or quite an obvious concept to address. But in some senses, it serves somewhat as a proof of concept for whether the data that we're suggesting represent mental ill health behave in the way that we might expect, in terms of whether people are more likely to be experiencing them following bereavement. And also, in essence, the novel aspect was to create a profile really of the people who would be most at risk following bereavement. And in that sense, we looked at two ways in which to group people. One is to group by bereavement circumstance, so to make a differential between people bereaved through illness, through sudden death, and through suicide as a discrete category, and to compare them to the mental health of the general population. And also to those who've been bereaved in various familial circumstances, bereaved of spouse, parents, child, or sibling, and so on. I will refer to this to some extent throughout the talk as the exposure to the particular circumstance. And also then people were grouped in terms of their socio-economic characteristics. So we could compare effects on men and women, on affluent and deprived versus deprived people, on people at different stages in the age spectrum. And in terms of which variables to focus on, this would be an opportune moment to mention that statisticians can be very tempted when you have a rich data set like the Census from which to mark different groups, to look at everyone and be tempted to compare every group that presents itself. But really, a combination of looking through the literature at the groups that have been of concern for a number of years, and expanding our network and speaking to the experts that already operate across Northern Ireland, and forming a knowledge exchange group of those individuals who could consult with us and discuss with us the particular groups that they found to be particularly at risk and were particularly curious about. That was invaluable in guiding how our research was carried out. And if you are one of those people, and I've spotted one or two of them, and you're sitting there, this was your shout out, and thank you very much for participating in that process. So just to describe briefly how the data set that we used is formed, because each study, though drawing on the same set of data that are available, is somewhat unique. So the resources that we were drawing upon were, as mentioned, the Northern Ireland Longitudinal Study, the Northern Ireland Mortality Study, the register of deaths that happen since the 2001 census, and it's notable at this point to note that the bereavement that we were observing was co-resident bereavement. So people who were bereaved of somebody at the same address as them in the 2001 census, and then linking that to the health card registration data that is held within NISRA, within the Northern Ireland Statistical and Research Agency. So that gave us our profiles, if you like, of people and of their experiences, and then our outcome variable as such is given by the enhanced prescribing database, which Aideen has been describing and is held within the Business Service Organisation, and these are combined then to give our grief study data set, which contains the pieces of information that suggest exposure and outcome to us. And just in 4 clicks, I'm just going to show you how the actual population for our study is formed. Essentially, you have a group of people who have been prescribed to, a group of people who are in the Northern Ireland Longitudinal Study. We need to exclude the people who can't experience co-resident bereavement because of their particular residential circumstances, or who can't experience the outcome as measured because they're too young. So people under 7 couldn't be prescribed and registered in the electronic prescribing database. So those two are brought together through. So those are the people who are in both the Northern Ireland Longitudinal Study and the enhanced prescribing database, and then unfortunately the people who are deceased in the meantime or who have emigrated can be studied separately, but can't be observed in the time period where we saw the eventual outcome in 2010. So in terms then of how you go about estimating bereavement effects, well, we used an operational measure of take a snap point in time in 2010 of January or February and look at one prescription, an antidepressant prescription at that moment, and compare the likelihood of experiencing that outcome for people who had no deaths within their household since their last enumeration at the census point in 2001, who were bereaved following an illness, who were bereaved following a sudden death, or who were bereaved following a suicide. And an important point to make as well is that we were able to account for the variation between GP practices, which Aideen has alluded to, but also to look at whether that would distort any model, any causal model that we would try and produce. And while there is variation undoubtedly between individual practitioners, we never found any evidence that it was particularly swaying towards that particular practices were swaying towards prescribing to particular groups of individuals. So to that extent, we can say something about the robustness of the results which I'm about to show you. But the major challenge which we have to try and overcome is that the likelihood of being bereaved and the likelihood of experiencing poor mental health are related in a clear sense, in that many factors which predispose you to one predispose you to the other. For example, deprivation and general health. And if you take the example of poor general health, you can imagine that if you're somebody who's experiencing poor general health, there's a likelihood that the people in your family are experiencing the same level of health because of some unobserved common factor, or because of health behaviours which you both engage in together. So your likelihood of being bereaved is increased, and your own likelihood of poor mental health arising from your other health conditions is increased. So we had to take account of general health in the model, along with a myriad set of factors, including the likelihood of mental health to people who provide unpaid care, for example, who are also likely to be bereaved and also likely to suffer poor mental health. But this is an advantage of administrative data sets, is that you can detect these groups even if you didn't necessarily foresee all the factors at the outset. So some of the findings that we produced using these models would be what you would imagine would be expected, and as I say, this gives us some confidence that the mental health measures we're using are behaving in the way that we might expect. So those are that bereaved persons in general had a greater risk of poor mental health at approximately 40% increase, and they also had a greater risk of being one of the people deceased in the meantime before the mental health measure could be implemented. And the risk was, as suspected, greater following suicide or traumatic bereavements, and I'll show you a graph which talks through this in further detail. Persons who lost a spouse or child had further elevated risk of poor mental health, and risk was also higher for older people compared to people aged between 25 and 64, who we would refer to as working age. And then some of the findings we might not have been anticipating quite as much. So as well as those who are over 65, people before the working age who are under 25 also experienced greater impact from bereavement than working age individuals. And also men were a lot more likely to experience poor mental health after being bereaved through illness, whereas women suffered more often following bereavement through suicide. So it's suggestive of some quite discrete mechanisms and some very different social contexts for different areas of bereavement. So the actual mechanisms underlying poor mental health in this circumstance become somewhat suggested to us through differentials like that. And there was no observable excess in risk to people bereaved in deprived areas, even after adjusting for the overall risk to those people in deprived areas. So bereavement not particularly impactful more than in the rest of the socioeconomic gradient. And the differential risk of suicidal bereavement compared to other sudden bereavement circumstance is not straightforwardly greater. It's quite complex, and which we can demonstrate in this graph. So the scale that we're looking at is the magnitude of the effect, where 1 is you have the same likelihood or the group has the same likelihood as the general population of suffering poor mental health. And the pattern that we see is for those bereaved of a child is, as we might expect, higher and higher again for people bereaved through suicide, though not to the point necessarily that we can definitively say that there's clear water between the estimate for those suicidally bereaved and those bereaved in other sudden circumstances, because the lines around those dots represent confidence intervals which overlap at this point. But we can say there's a clear differential between suicide and illness for bereavement in the circumstance of parents being bereaved of children. But this same trend isn't necessarily repeated in other categories. So you can see quite a different shape for people bereaved of a spouse, where there isn't a clear differential necessarily at all between sudden and suicide bereavement. So it's suggestive of a complex mechanism which needs to be carefully teased out. And there are, of course, limitations to using administrative data in general and in this particular context, in that some of what you might ask in a survey won't necessarily be available to you. By definition, these data were collected for other purposes to administer to the general population, and they're being used secondarily by researchers, and researchers need to make the best accommodation with the data that they can be supplied with. In the particular case of medication, there's a long argument to be had about whether it focuses on need or whether it focuses on the people who are using and seeking this particular form of help and treatment, and what it actually is an indication of. But again, there's increasing research coming out to say that it's overlapping to a great degree with other indicators that you could use of poor mental health. And again, almost by definition, there is an administrative overhead to using these type of data, which involves a particular systemic knowledge of the infrastructure of data which are there, and the protocols which need to be adhered to in order to use them in a responsible manner, all of which falls jointly on the researchers and the people who are supporting them. So to make a conclusion from what both Aideen and I have been talking about, administrative data is a tool which we can use to address the questions which arise regarding mental health and which are of interest to all of the people who are interested in improving mental health, to policymakers, to people planning and providing the targeted services, to various scientific communities, and to all of us who all of us have a stake in the greater understanding of mental health, whether it's our own or that of the people around us. And looking to the future, similar data, infrastructure and resources could be used to monitor how successful we are at tackling the particular problems which attach themselves to mental health and population level mental health. And there's some information on the slides that we've given out as to how if you're interested in accessing administrative data, some of the channels and infrastructure which are currently being put in place and being built. So if you want to have a discussion with us or with any of the parties mentioned on this slide, I'd greatly encourage you to explore how your particular area of interest could be explored using administrative data. Thank you very much.